Well, hello, good evening, and welcome to the Institute of Healthcare Management's latest in its now famous HealthChat series. And tonight we're going transatlantic. We have the fabulous Jason Helgerson, CEO and founder of Helgerson Solutions, and previously, more importantly perhaps, the head of the New York Medicaid program. Before that, I think, head of the Wisconsin Medicaid program. So we're going to find out all about the response to COVID on that side of the Atlantic and compare and contrast to this side of the Atlantic. And who better to have as the foil to the transatlantic activity than the fabulous Roy Lilly, who's of course sitting in London right now. And I'm just going to hand on to Roy. If I may, just first, Roy, just say to people, if you've got questions that you'd like to ask, please use the Q&A and the chat facility at the bottom. And after about half an hour, we'll do a facilitated Q&A session with Jason. But for now, over to you, Roy.
John, thank you very much. And Jason, welcome from New York. Isn't it fantastic with Zoom, what you can do? How have you been? You okay?
I'm well. I'm well. Obviously, we live in interesting times and challenging ones at that. So, but I'm very well and pleased to be here tonight.
Well, that's great. We'll find out how interesting in a minute. Well, when you start a conference, this is a live conference. There's people always coming in late, aren't they? And they sneak in like they're invisible. We try that. So we just let people settle down. They sit down. They'll bring their cup of tea to the screen. They get themselves comfortable on the sofa with their laptop on their laps, and the late joiners are still trying to figure out how to turn the sound on, but we're all good to go. So if everybody's ready, we'll make a start. Well, Jason, I think you and I last spoke, I think it was two or maybe 3 years ago now. You were over here doing a tour. You did some work, I think, with NHS England. You went to the Jewel in the Crown, the Isle of Wight, and I think you and I did a session in Guildford for the HEFMA, the NHS Finance Managers. Yeah, NHS Finance Managers Association. I look back on that fondly. That was a good gig, wasn't it?
It was great. I've done a number of events with HFMA over the years, and was pleased to be there for that. And it was great to have that conversation. I just wish we were being able to do this in person.
Yes, well, me too, absolutely. Well, I think that interview, we put it on Periscope, and I think it ended up with 10,000 people in the end who'd viewed it. So thank you for doing that. And the HFMA is still going strong. They concentrate on finance and we concentrate on management. So they're a great organization. Well, I mean, New York, everybody knows New York, of course, but New York has become really famous here during the COVID crisis. I mean, with the fabulous governor of New York, Andrew Cuomo, who actually had his daily press conferences broadcast live on Sky Television. I mean, I have no idea why they stopped it, because it was riveting television. He's a really great guy. Yeah. And you work with him. Do you know him quite well, I think?
Yes. So he was my boss for 7.5 years when I was, in fact, he's the guy who recruited me to come to New York, was to work for him and to work for run the New York State Medicaid program. So I knew him very well. I know him very well. And he's, I think ultimately he's exactly the right person to lead a state in these kind of very challenging times.
I think he's a great guy. And the reason that I think he was loved so much here is that we were having a daily press conference from number 10 Downing Street, which was very stilted. And, people stood behind a lectern and they kind of lectured the public, and said, this is the policy and this is what you're going to do. And these are the numbers and and a rather anodyne press involvement, which was frankly useless. But Andrew just kind of sat there, didn't he? And said, well, this is what I'm doing. I don't know if it's right, but I think it's the best I can do. And yeah, we haven't got any ventilators. And if anybody knows anything how to make a ventilator, give me a call. Yeah. And the press were asking questions, and he was saying, well, geez, I don't know. I've never done anything like this before. I mean, this is my rationale. This is my thinking. He was so disarmingly honest, I thought.
Yeah, and I think that's what really what people not only in the UK but all across the United States have found really refreshing, and particularly here in this country, where I think people found the responses from Washington, the approach from Washington, to be inconsistent at best. And people were looking for someone who was more of a straight shooter, somebody who would just say the facts as they had them. And I think the other thing is there's so much uncertainty about all of this. And I think that, the best example of that has been the models projecting what the infection rates were going to be, the hospitalization rates, the need for ventilators was going to be. And I remember in those the earlier days of the crisis, the projections which he was showing on screen were suggesting we would need twice as many hospital beds as the state of New York possessed. It was just, I mean, you were looking at that and saying, if this turns out to be real, this is going to be the biggest public health disaster in the nation's history, that people were going to die, waiting for a hospital bed. Yeah. And they'd be making terrible decisions. He was showing that when others probably weren't willing to do that.
Absolutely. He was showing the refrigerated containers parked in the street, with sadly dead bodies in it. But I mean, he just didn't wrap it up, did he? Either and of course, the other thing that was so interesting about it was like a reflection of what was happening here. We didn't know where we were going to get ventilators from. We had trouble with, and then he didn't know where he was going to get ventilators from. So, he asked industry to make them. We asked industry to make them. There wasn't enough PPE. We didn't have any. He didn't have any. And it was really interesting to compare and contrast the approach. Here, the government kept saying, oh, well, we've got the best procurement people in the world, and we've got enough, and we're going to get enough, and we're bringing it in, and blah, blah. And Andrew Cuomo was saying, we haven't got enough PPE, and I don't know where the hell it's going to come from. So if you can help, give me a call.
Yep, exactly. And I think that's the truth, speaking, the truth that people were so eager for. And the other piece of it too, I think, is science, and letting science drive decision-making to the extent, and I think appreciate the fact that science doesn't always get it right. As those models turned out, fortunately for us, weren't correct, right? The infection rate wasn't as bad as was feared. But I think that's you have to be sort of, you have to be truthful with people, both in terms of what but also truthful in the sense of what you don't know.
Yeah, that's an interesting point about the graphs, because we had a kind of similar problem here. There's a very prominent epidemiologist who works at Imperial College, and his work originally said there were going to be 300,000 deaths, or just a mind-blowing numbers. And I think the government kind of panicked at that point. You had similar forecasts that weren't right. And then we went the other way, and our chief scientific officer, Sir Patrick Vallance, said, "Oh well, I know. I think it wasn't him. It was the chief medical officer at NHS England. Let's get it right." He said, "Well, if we have 20,000 deaths, then that'll be about it." And of course, here we are at 47,000 now, and we still don't know how it's going to end up. Why do you think it is that the forecast was so wrong?
So it's a good question. And I think if you asked Andrew Cuomo, he almost in every one of these most recent press conferences, he always talks about he goes back to the models himself. And he remembers in them being presented to him that they always came with this caveat: we don't know how effective social distancing is going to be. We do not know how effective the stay-at-home orders are going to be. We don't know how effective masks are going to be. And so that was always a caveat. But I just think at the end of the day, there was so little we knew about the virus and its nature and how it spread. There's still, we don't know, a lot we don't know. So I think that that's ultimately, and my one fear out of this is that the next time we have a pandemic, global pandemic, and we are in the same situation where we don't know, people will look at the models that are used then, and either would do one of two things. My biggest fear is that people just ignore them. and they say that they're artificially inflated, and we under respond. In this
Yes.
case, we probably over responded in some ways, although it's still probably early days to make that full determination. But in some of these cases, I would rather have over responded on things like hospital beds and ventilators than have under responded and seen the carnage as a result.
Yeah, it is interesting. I mean, we have, as a government, we have rehearsals here for major, civil emergencies. I imagine, like you do in the States, everywhere, really. And of course, our rehearsals and our thinking is all, and I've done them myself. I mean, I went to the Civil Defence Training College as a community leader when I was a council leader, and did their course, and it was always about a pandemic of flu, the influenza. Mm-hmm. And the thinking was that, we kind of know how to treat flu. We may not know how to treat this particular strain of flu, but it's flu and we can get a vaccination, blah, blah, blah. And all the scenario planning always culminates in having a vaccine or whatever. Because what we haven't done here, and I don't think you've done it in the States either, we didn't really rehearse around a novel virus, something that we really didn't understand. And I think, truth be told, we still don't really understand it.
Right. No, I agree. I mean, I think a lot of it was, a lot of the conversations thinking back to pandemics, I think of it as being either a flu-related conversation or AMR, antimicrobial resistance. So this sort of super bug that normally would be treated with antibiotics that was resistant to it, which still is something we're not talking about it today, but we need to have a conversation about AMR because that is a real threat that could create a very similar, if not worse, situation than we have today. But you're right. I don't think we did that. And I don't know about you, but my experience, and I've done many of those, we call them tabletop exercises, right? Where you sort of play out these scenarios, is that
you try and frighten everybody to death. Yeah.
Yeah. But it always felt, to me at least, it felt artificial. And because they're trying to compress it into such a short amount of time, and such, it didn't, I felt like it wasn't as effective at helping people really prepare and have the right skills that you need. And I hope, if nothing else comes out of this, is that we're going to have a serious conversation about how to really effectively plan for this in the future. But and as I say, PPE is a good example, regardless of whether it was the flu or a virus like this or AMR or whatever. PPE is something each country should have a national stockpile. Right. We should have a greater supply than we have, and providers need to have their own stockpile. I mean, that's just something where no matter, all the prep we did, all those scenarios we ran, somehow didn't inform us that or encourage us to put together the right set of PPE.
Yeah. And the PPE, I mean, let's just kind of hover over that for a moment. I mean, the amount of PPE that people were getting through, and indeed still are in some of the intensive therapy units. I mean, the consumption figures were colossal, and I'm not sure really. I think, well, what would I have done in the circumstance? Would I have ever envisaged that amount of changes of stuff in a day? And then of course the knock-on effect is how do you get rid of all that stuff? I mean, the public don't know about this, but the difficulties we've had with the Estates Department of disposing of this toxic stuff, where do they get rid of it? And hospitals are used to getting rid of toxic clinical waste all the time, but not in these volumes. And there was a capacity issue about how we got rid of it all. And I guess, you had the same sort of problem, and no one was prepared, I think, for that.
No. And I think it was, and obviously the other thing about this little bit lesson learned was the first wave of focus was on hospitals, rightly so, because that's where the first really, really sick people were going into, and people were very fearful about the hospital capacity and hospital PPE. But what we failed to do was to then look where else are there high risk. And I think that what we didn't do is then shift enough resource or spend enough time and effort preparing for what was the next crisis area, care homes, or as we call them, nursing homes in the US. where obviously, at least in New York's case, 14% of all deaths in New York State have been in these care home settings. And it, taking a step back now, hindsight's always 2020. You look back, you say you have a population of elderly, high acuity, high needs individuals, very frail, and where disease can spread very, very quickly. And the fact that a lot of those organizations, institutions didn't have PPE, were not prepared, did not have the protocols in place, and we didn't tack towards that problem or potential problem until, frankly, it was too late.
It's extraordinary, isn't it, how we've had the same problem here. We cleared out our hospitals. We cleared 33,000 beds, which is the equivalent of 10 hospitals. And they were mainly frail elderly people. And we said to the families and to the frail elderly, listen, you don't want to be in hospital at a time like this. We're going to put you in a care home. Don't worry about the fees. We will pay the fees. So the families and the people said, okay, fine. The care home's, safe care. I get it. It'll be safe. We sent a lot of people without testing them to know whether they had COVID-19, CV-19 or not, which now everybody's saying, well, that was crazy. A lot of people claim they were tested. Some people they weren't. I mean, the whole thing was a muddle. And then we put them into care homes. And I don't know what it's like in the States, but certainly here, we are beyond, with elderly people, we're beyond the common understanding of what care is. I mean, care homes are, in the public idea, it's like elderly people being together with, their friends of the same age, discussing their grandkids, having a good time, cream teas, singing, Vera Lynn songs and the White Cliffs of Dover and waving the Union Jack. And, they're having a great time. It's one big tea party. But actually, no. I mean, now the care homes are full of people with comorbidities. They get along okay, but they need a lot more than care. They need nursing care. And of course, when you put people, the elderly people we took out of hospital, into that environment where they're looked after by people who are low waged, low skilled, often English is not their first language, with places, as you say, they don't have infection control protocols in place. Why should they? They have only basic training, and suddenly the whole thing blew up in their face. Looking back on it, as you say, hindsight is 2020, it was obvious.
Yeah.
But it wasn't obvious at the time.
It wasn't. And that's the thing I think is that, Roy, is you make a key point. I think this is going to lead to a very, very serious conversation. I think in probably both countries relative to the future of how do we care for the elderly, right? I think that a lot of people, elderly and their family members, are going to look at this experience as being, I don't want to be, or I don't want my loved one to be in a care home, that it's going to be seen as a dangerous place. And people are going to do everything in their power, including advocacy for public policy change, to keep people out of having to be forced into that environment, which is going to put a lot of pressure on the governments to come up with alternatives and reimagining the role of the care home in the future. That's certainly a conversation you're beginning to hear here in the United States. And we'll see where that goes. But I think that's going to be something we're going to talk about even more in the future.
I do too. I did a conference day before yesterday of investors in care homes, and they weren't very pleased with what I said because I kind of stuck it on them. But I mean, really, even from the funding point of view, it's hard to see why funders would want to fund a care home, given now the risks. Yeah. And let's face it, this is not over, and we're going to see all the litigation coming out of this. A lot of people are going to sue a lot of care homes, I think. Yeah. For what has happened, and that is not to say the actual people doing the jobs in the care home haven't busted a gut, and they've been terrific, but the system that they're working in is no good to them, and it's no good to the elderly people either. Right, let's talk about testing. We've had one or two problems with testing here. We had a system for testing which was run by Public Health England, an organisation that I know you know. They thought it was robust enough. It wasn't. They were counting testing as being successful in the thousands when we needed to talk of it in the hundreds of thousands. We still can't manage 200,000 a day. How was testing for you, darling? How was testing?
So I think it's the governor's biggest success in all of this response, in addition to his communications strategies. But in terms of tangible response, I think testing is the greatest. Over 3 million people in New York have been tested.
Wow.
Yeah, and to a great extent, with like very little help from the federal government, the state really tapped into the healthcare system and different types of like hospitals and other types of providers, in addition to opening it up to private labs and being very, very aggressive in getting tests. In fact, I know that they for a while were redeploying people from the actual state health department to assemble tests to be distributed out to the field. I mean, tremendous effort was taken to, because there was a big belief fairly early on that we needed to be able to do testing in a pretty rigorous way. So New York was the first place in the United States to do the drive-up testing, and particularly New York City was very, was sort of, there's anybody who wants a test in New York can get one. And the policies have, were liberalized here in terms of who get access tests much earlier on than almost anywhere else in the United States. So I think it's really been a success in the sense of getting that many. I mean, what's funny is that when you hear the president talk about testing, he talks about, one, it's important. People should be able to get a test if they want to. But then he, out of the other side of his mouth, he says, well, if we test people, it makes us look bad. Because when you test people, you're going to get positive results. In New York, we've been as aggressive. And I think what is true is in other parts of the country, you have underreporting because the states have not been nearly as aggressive. And so we have a lack of uniformity in the country in terms of access to testing and just in terms of how testing has been rolled out.
Yeah. I guess also it's worth just hearing from your word on the healthcare system in the US. I mean, it's got a lot of critics here, of course, because of its insurance base and its cost. Medicare, Medicaid, a lot of people don't quite understand the difference and how it works. But I mean, it is true to say that a lot of Americans still have trouble with getting universal access to universal healthcare. You have a federal system, don't you? I mean, it's a bit like Germany. People say, oh, the German system's terrific. Actually, no, there were 60 federations in Germany, and they had a hard time as well. You had a problem because there was you just touched on it. There was a tension between the president and the center, Capitol Hill, what the states wanted to do, what the governors were saying, and of course, drawing all of the players and the payers together. I mean, Cuomo looked to me like he effectively nationalized the whole system overnight and said, if you're in healthcare, you work for me now. This is what you're going to do. And I thought that was a really interesting approach. And it points, doesn't it, to needing to have that coalescence of systems.
Yeah, and I think this is at least what I hope comes out of this in the U.S. context is we begin to think more about healthcare as a system. And if you ask most Americans what the healthcare system is, they'll think of a single employed entity, a single hospital system as a system. And yes, it'll have clinics and it has doctors and it has different types of services it provides, but it all sort of markets itself as a single system. So like the Mayo health system in Minnesota as an example. That's what most Americans would think of as a system. They don't think of it as a geography. They don't think of it as a group of organizations in a community working together as a system. And I think that definitely one of the governor's big lessons is the need for that coordination. And what you described is he basically brought in New York City all the hospitals together and he said, we're going to operate as a system. The policy of, well, it used to be the case was that hospitals, A&E got overwhelmed, reached a point, it would basically trigger a basically stoppage of its A&E, would accept any new cases, and then someone would get rerouted. There was no real communication about priority. People who were very high acuity would be sent very greater distances, risking their lives. There was no real system to all of that. And I think, and what he found was that at the end of the day, there was no real way for these organizations, independent, to actually communicate to each other, share resources, make sure patients were going to the place that was best fit for them, regardless of how their healthcare is paid for. And he really did come in and institute controls and approach that was much more along those you described nationalized type effort. And I think it really did help to ensure that the crisis wasn't worse than it was.
Yeah, I think he played it blinder. Now, of course, everybody's tracking and tracing. We're all bloodhounds now. We're all trying to find. We've recruited an army of trackers and tracers. I mean, we got no data. We've only had one lot of data, which is pretty pathetic. But hey, it's just starting up. We're starting from scratch. Well, there should be more data tomorrow. So Friday tomorrow. So we should find out, whether or not they've got some traction. How are you getting on with the tracking and being the bloodhound?
So yes, very similar thing. And in fact, the state has been divided up into regions, and regions of the state are able to reopen if they can hit certain thresholds. Some of those thresholds are related to infection rates, hospitalizations, things like that. But also one of those criteria is how many tracers have been hired and are available to follow up on any cluster that may materialize. And so that has led to a lot of activity at the local government levels across the state to hire individuals to be in those positions. So far, at least, the infection rate now in New York is the lowest in the country. We were number 1, and we're now number 50. And a lot has changed, obviously, in the state. So, but those people have now been employed. The state does also have a technology solution that is developed, but the word from the street so far is it's clunky at best and isn't working as the local officials might have hoped. Unfortunately, we're building all this stuff on the fly. And this is, I think, another lesson out of this is we've so underfunded our public health function in this country that here we are trying to design a solution to support tracing or activities when we've all known for quite a while that this was potentially an issue. A pandemic has been a risk for a long time. And it's only now in the midst of one that we're actually are looking at technology solutions. But I can't say that our solution yet has been proven in the field to be effective.
No, we got exactly the same here. The NHS decided it would build its own system. Apple and Google have a system. I'm sure you know that. They're
Yes.
global businesses. We chose not to use that for reasons that are not entirely clear to me. There was something about it not being interfacing as well with data at the center. And I'm not qualified to know, and I've never met anybody that could really explain it other than just, if it's not invented in the NHS, we don't want to use it type of thing. And so we've struggled with an app that has been working in the Isle of Wight, which you've been to, I know, because
Yep.
you've been out there and seen St. Mary's and the hospital there. It worked indifferently well, I think it's fair to say. I mean, it didn't go wrong, but it didn't really make the big impression that I think everyone thought it would. And the big issue is the interfaces. It told you to go and get a test, and then so you had to get on the phone, and the phone wasn't answered, and the test didn't get delivered, and then it didn't get picked up. So it was the interfaces that were the problem, not so much the app. But why do you know why New York went its own way with an app? Is it just there were a lot of app developers there who wanted to do something?
Yeah, and I think the question is, at the end of the day, I'm not that familiar with the final decision-making process, but I think that the Apple Google solution that it works for Android phones as well as for iPhones, but not everyone necessarily has that or a more of a recent version of the app. So I think there was concerns about the applicability of that solution across the entire populace. And so I think that might have been part of it. But I think all of this to me, Roy, is that I'm not entirely convinced that on the fly, what we're doing right now in the midst of this pandemic, we're going to be able to design an app and a tracing solution that's actually going to meet our needs. that I fear, I hope I'm wrong, but I fear that the process will be full of too many holes and too slow, too effective to really achieve the goal. That we will have to continue to wear masks. We'll have to socially distance. We'll have to, limit our economic and personal lives until we have the more effective treatments, and or a vaccine. Well, and then eventually here, but I do think that I have a suspicion that the ultimate solution here for tracing is potentially going to require an infringement on people's privacy that will probably require a national debate as to safety for the community, for the public's health, versus how much freedom and information should the government and its agents have control.
Well, I mean, we've had a similar debate here. The app collects data here. They're talking about keeping the data for 10 years because they want the scientists to be able to study it. The epidemiologists wanted to be able to study it. And of course, it is a rich source of data. But there are those that say, no, I don't want my data kept for 10 years. I mean, frankly, if it's not anonymized, it's pseudonymized. So personally, I don't think it's a big risk, but a lot of people do, and we have to respect their views, I guess. But you can get around it with sunset clauses in legislation and stuff. I mean, you can do what you can do if you want to. The two things that come out of it, I mean, you say, without a vaccine, we're stuffed. But there is antibody testing, isn't there? Now, we're having a go at antibody testing here. We're spending a lot of money on it. People have been offered to buy antibody testing privately, and then the medicines regulatory people jumped all over that and said, no, the public can't be trusted to conduct tests on themselves properly. Like people with diabetes don't test themselves every day, really, like we're all stupid. But so they jumped on that, and I think they jumped on it for other reasons, more sinister reasons, like it doesn't work. And now the NHS is saying, well, if you want an antibody test, we'll antibody test the staff. But NHS England, the boss organisation, is saying it doesn't work. There's no guarantee that you'll be immune from any future infection. So, I mean, I don't know, where are you doing antibody testing? It seems to be a complete waste of money to me.
Yeah, I mean, there's antibody testing being done, and there's more freedom here in terms of who can access the antibody tests. But I think most people have a very dim view of it as a strategy. There's much more focus on the concept of not just the vaccine, which obviously also there's a lot of questions about, will we ever get a vaccine that the silver bullets, the polio-like vaccine, right? Where we basically make sure that once you have this magic jab, there's no chance you ever get it. People question whether that's really possible. But I actually hold out better hope for just flat out better treatments. So that, so as a result, people will still get it until we really have eventually get to herd immunity. But that the problem, a lot of this is that because we didn't have good treatments, the health system gets overwhelmed, people get super sick, people die, is that if we can get better treatments, more effective treatments, I'm very optimistic about that. We'll get better at treating this. We already are better treating it. But obviously we all hope for the silver bullet vaccine. But I just think those things will come one way or the other, probably faster than we'll have some perfect tracing system. But even then, I mean, look at what's happening in China, like as we're speaking.
Beijing today.
Beijing, right? Yeah. Where they've had to close down a big swath of the city. And they have obviously an ability to impose the government's will on the people that would never be acceptable in the UK or in the US. And even there, with that kind of power and resource that's deployed to it, they still can't prevent outbreaks.
No. And New Zealand, of course, some Brits have gone over there and it's all kicked off again. Thank you very much.
I did not see that. That's amazing.
Oh, yeah. Now, New Zealand are very upset because they got in and got out quick, locked everything down.
Yeah.
And a couple of English tourists have turned up on a flight via Australia, infected 3 or 4 people, and it looks like it's kicking off again. So, right, John, I've got an eye on the time. I know you got some questions. Let's find out what people are asking.
So first up, we got Phil saying, Are the UK and USA equally poor in their response to CV-19? And if so, why?
So
Please listen to the last 20 minutes, I think.
My response to that would be is I think about this and people have criticized and said, well, if the governor's response, and he's been praised by a lot of people for the response, if his response was so good, why was the outbreak so large, so significant in New York State as compared to other parts of the country? I think New York was the most logical place for this. I mean, it's a global city, people flying in from all over the world. It's the densest place in the entire country. I think we're going to learn a lot about how the disease spread in the city and the fact that people live in very close quarters and the disease spread very quickly, particularly among families, close relations, living together. And I think we're going to find that was a key reason, that the density of the city, which is often it's a positive, is really a negative in the case of the pandemic. So I think it's hard to say that the level of outbreak, whether I don't think the government was super slow in its response or not aggressive enough. But I would say is that we talked about some of the other failings. The one thing we didn't talk about, Roy, is the racial disparities of the impact of this pandemic. I was just looking at some numbers just in New York. When you age adjust the death rates based on race, and New York's been very transparent with these numbers, the results are staggering. For whites, the death rate is 27.8 per 100,000 people, but for Hispanics and Blacks, it's over 100. So basically 4 or 5 times a higher death rate when you age adjust for people of color. And it's just, and that's a story. And obviously with all what you're seeing around the Floyd murder and all the other things are happening in the US, those two issues are very much coming full circle.
Yeah, we have had the same issue here. The government's been under pressure to produce a report. Public Health England produced a report. Some of the early report, the first iteration of the report, had a whole chapter deleted, and that was the contributions from the organisations that represent Black and ethnic minority groups. It's been republished again today. It's a very anodyne report, and they're now saying there'll be further inquiries into. But it's obvious what it is, isn't it? It's poverty, it's social deprivation, where this part of the population is more represented. I mean, it's not entirely true, because we've had doctors and nurses from Black and ethnic minority backgrounds, and their social their social position in hierarchy is probably different, but nevertheless, there is an inextricable link between poor people doing badly in healthcare, and they're often represented in those groups. We've got exactly the same thing. No one has a clue what to do with it, and everybody's parking it, as far as I can see, until all this is over, whatever that means.
Yeah.
And of course, you're in a fortunate position, really, in the US, when there's nothing to compare with the US. So however well you've done in the US is very subjective. For people to make their minds up about, how's the US done? You may be able to compare the states, but they're very different as well. Here, of course, we're compared with Europe, where people do find comparisons between Germany, France, and Italy, and to some extent Spain and us. And in those hierarchies, we've done poorly on a lot of counts, and certainly the death count. The government is saying, well, it's too early to tell. We came in a different synchronization, and we're different in the cycle, and blah, blah, blah. But at the end of the day, you can't disguise the fact we haven't done as well as a lot of our European neighbors.
Yeah, I mean, I think Germany is very interesting in terms of their response. And I think there's a lot more study that needs to go into this to understand why death rates varied, why the spread and the level of positive. I mean, positive results are often a reflection of how effective you test. And so places that do no testing are going to have no or very few positive results. The only people who get positive are the ones who show up in the hospital. So but there's definitely, we need to learn something from this, Roy. I mean, if we don't learn from this, this is certainly not the last time. We should have learned from SARS. We should have learned from, past viruses that came to our shores that weren't as bad. We didn't, not as many people died, not as people got sick. We didn't have the economic fallout from having to do stay-at-home orders. But we should have learned from that. But we got to learn from this, because we shut our global economy down and threw millions of people into unemployment and to try to protect ourselves. And if we don't find a way to protect ourselves better up front, then shame on us.
Yeah, I think very wise words. John.
This is an interesting point. We've had a lot of emphasis here in the UK, Jason, on population health management. Really, it was a phrase that was coined in the long-term plan, and it's become a much more obvious means of sort of defining how we're doing. Questions come in: do the hospitals in New York have a wider agenda that incorporates population health management? And if so, how is that evolving and developing? Has it worked?
So population health management is almost ubiquitous now in American healthcare. People use it all the time. Now, in some ways, it's almost so ubiquitous that there's no sort of standard definition of it. People use the term in somewhat different ways. But yes, I mean, many organizations, when I was there, we drove efforts to create, in essence, integrated care systems that were very much, basically entirely focused on population health management. But traditionally, what we're talking about here with the pandemic, this is sort of been separate. Healthcare providers haven't necessarily seen as part of their responsibility, other than to follow the government's direction on protocols and things like that. But generally speaking, it's been left to the governments, particularly state and local governments, to be prepared for and be in a position to evaluate and determine the spread of a virus like this. And so that's typically not been part of the conversation about population health, but I think that's actually going to change. I think that we're going to start thinking about this much more broadly, because I think that at least in the conversations I'm having with providers from very different situations, is that no one that I talk to thinks this is it. Like, this is the end. Like, this is the last pandemic. That we've got to build this into our operating models within the healthcare provider community to be thinking about how to more effectively respond as organizations, how to build relationships with other provider organizations, how to see the needs of the population, particularly back to the racial disparities, that we need to think about how to prevent the spread of this disease more effectively. I think that one of the things we're gonna find is, and we worked on this, is that we're gonna need alternative housing strategies for virus or whoever is sick in the future. We're gonna need to deploy, put them in hotel rooms or something, but because what we're going to find is that we sent far too many people back home into very dense housing situations, and not people who needed to be hospitalized, but they got a positive COVID test or were symptomatic. We sent them back home. They spread that disease amongst their family in that housing. We need a different response to that, and that, I think, is going to trigger a population health kind of conversation.
Interesting. John.
Final question, really, which is, there's a whole question about league tables, actually, that we might want to reflect on after this, as to whether it's useful or not to say who's top of the league, bottom of the league, or whatever it is. But if the New York state is now bottom of the league, are other states now looking to mirror your approach? And how is that being facilitated? Is there a sort of a collegiate Academy of Fabulous Stuff approach to this?
That's a great question, and it actually depends, and politics plays into this tremendously in the United States. Certain states have been very aggressive, and I'd say not just Andrew Cuomo's a Democrat. Other Democratic governors have been very aggressive in their response, but also some Republicans, including some pretty conservative Republicans, like the governor of Ohio, has been praised for being quite aggressive. And But I do think that you look across the nation and you see some states, Florida is a good example, Arizona is another example, where they were slow to close and quick to reopen. And you're now starting to see spikes. Florida, I think, is becoming one of the new epicenters for this. There was the pictures of the people on the beaches in Florida, in essence, spring break Florida, as if, nothing had ever happened. There was no pandemic.
We had the same thing here in one of our holiday hotspots, Weston-super-Mare, beaches packed.
Yeah. So I think that you are starting to see that, and I that's why the music's still playing here, and so we're gonna have to wait and see whether or not these states that now people are asking those governors, do you want to put in greater restrictions? And so far, at least, they've resisted it. So we'll have to see, but yeah, those states that really in the early days were, low infection rates are now much higher. And but I don't know how many of those governors are pick up the phone and calling Andrew Cuomo saying, hey, what advice do you have? I think some of them still think this is an overblown thing. It's really not that big a deal, and are fearful of the economic consequences of a more aggressive action.
I've just got my eye on the questions, John. There's just one there from Anthony Bowen. You see that one? If we could perhaps do that one. He's just asking, how is healthcare financed across New York? It'll be private healthcare insurance, I guess, but there's a big state contribution, isn't there?
Yeah, in fact, New York, it's sometimes underappreciated is how much government money actually is in American healthcare. In New York's case, 50% of all the money in the New York healthcare system comes from the government. And the two big programs are Medicaid, which is the program I ran, which is about a $70 billion enterprise. And then the Medicare program, which is run by the federal government. Those are the two largest payers. And then the rest of the system is commercial, we call it commercial insurance. Most of that's large employers who buy health insurance for their employees, which is an interesting history. We're the only country in the world that links health insurance to employment. And most Americans still, 60+% of Americans get their health insurance through their employer, which is a uniqueness to history that dates back actually to World War II. During World War II, when wages and prices were frozen by the government, unions and large employers didn't have anything to negotiate over, and at least in the traditional way. So they negotiated over healthcare. And that started the idea of employers, these large employers, offering health care, at least health insurance, what it eventually became, as a benefit to their workers. And that's the reason why we have commercial, private, mostly employer-based health insurance.
Really interesting. Well, I think John's signaling me that we're against the buffers of time, I think now. It's been fascinating. I don't know where the time's gone, Jason. It's been fascinating to talk to you, and thank you so much for your time. In a way, it's kind of reassuring to know that we've done things as badly as others. It's probably not the right thing to say, but I mean, certainly, let's put it this way: we both face the same problems, I guess, and in the end, we'll have to figure out what the solutions are right for each of our two countries. So listen, thank you so much. Travel safely. Are you planning to come back here at all anytime?
I would love to. I have a planned trip in December. We'll see if that is possible. The 2-week quarantine requirement is a little bit of a deterrent at the moment.
Yeah, I think we put a sign on the door saying welcome, but not really. But anyway, when you come, you'll be very welcome, and you must come and meet some more members of the IHM. And you're a fascinating guest. And Jason, thank you very much. Over to you, John.
Thank you, Roy, and thank you, Jason. Just to say to everybody, if you are interested in further things that we're now putting online, we've got Professor Rebecca Mulby next week on June the 24th, Wednesday, June the 24th, talking from her university's perspective as all the lessons that we can take from the positive lessons we can take from the COVID experience. And then we have a special insight about redeployment of staff at Guy's and St Thomas's Hospital. That is on Thursday, July the 2nd. There's all that and more, all within the IHM membership. It's the most sensational value. Do please, if you'd like to just experiment yourself to see if it's for you, it's free to enroll as a member until the end of July. After that, it's your business whether you choose to stay with us or not. Hint, hint, you will. So if you go to the ihm.org.uk, that's where you can enroll for free until the end of July. All that remains to say is, once again, Jason, thank you so much. It's been absolute barnstorming performance. Thank you, Roy, and stay safe, stay well, everybody, and thank you for the brilliant work that you're all continuing to do. Bye-bye.
Bye.